Hello, everybody. This is Dr. William Shear calling from Delray Beach, Florida. Most of you, the physicians in the group, I know there's a few logged in, certainly know who I am. I've been a member, a proud member of the FPMA for over 30 years. I am from South Florida. I graduated University of Miami. I was the first student to be admitted to Barry University School of Podiatric Medicine in Miami. I was part of the charter first class that graduated in 1989. And a little FYI, I was actually the person who created FPMA.com. I don't know if anybody remembers that, but way back in probably 95 or 96, I was only in practice a few years, and I was really technically savvy, and I wanted to get the URL fpma.com. I didn't want the org or anything like that, so I actually registered it in my own name. And for 2 years, I was the webmaster for FPMA. And then basically, once they wanted, I kindly just kind of gave it to them because I really think it was nice that we have that URL. So the FPMA has done a great job for over 30 years. I've been to probably almost every SAM meeting. That's one of my favorite meetings of the year because, truth be told, I'm a Disney guy. I love going to Disney World, and you don't need to twist my arm to go to a medical meeting that I can actually write off to go to Disney World. I know we do have a lot of assistants here, and I know that my office manager, I would always take to the FPMA SAM meeting. So those of you out there, if you want to use my name with your employer to say, hey, Dr. Shear said we should go to the FPMA SAM meeting and you should pay for that. Now, a lot of the podiatrists out there are a little thrifty. They're going to want to put you maybe in the Motel 6 instead of the really nice Coronado Springs. But again, try to twist their arm, say, hey, look, I was really good. We had a good year, and certainly you'll have a lot of fun. The SAM meeting is a highlight of the year. And the fact that we started in January kind of sets the tone for the rest of the year. It does seem a lifetime ago, the SAM meeting 2020. Everything in life was going fantastic in January 2020. Even February was going pretty good. And then about mid-March, we kind of all slid down with COVID. Just like you and everyone here, I hope and pray that we kind of get through this difficult time. So today's topic is produced specifically at the request of the Florida Podiatric Medical Association. And they said, hey, Dr. Shear, can you create a lecture for our assistants about sampling techniques for let's say, skin biopsies, nail biopsies, and specifically, what are the fixatives and specimen collection technique that you use to send to laboratories? Because there's a lot of questions on that, mainly because if you choose the wrong fixative and you choose the wrong sampling technique, you're really not going to get the results that you would like to see. So in terms of a true disclosure, I am a senior podiatric medical advisor, a clinical consultant and speaker for Bako Diagnostics. And basically, we want to thank them for sponsoring this meeting. I am not an employee of Bako Diagnostics. I'm just really the senior podiatry advisor. This is the largest podiatry laboratory out there, dermatopathology laboratory that focuses on podiatrists. And they certainly sponsor pretty much all of our major events as a platinum sponsor for the past 10 years. And we want to thank them for that. The other thing I do want to give a little plug for is you can download this little booklet. This is a little booklet that I actually am the lead author. I was the one who kind of created this. This is a brand new version 2.0. If you got this last year, you got kind of the horizontal one that kind of looked like this. Which is actually still pretty good, but the brand new one is the smaller one that looks like this. And if you want a hard copy, you're going to actually have to attend the one of the live meetings or go to the sales rep or send an email to the company. But if you want to download the PDF, which is everything the paper guide has, but in a PDF format, pretty much go to the Bako DX website and basically you can download that. And this is a 14-page guidebook with everything you need to know about biopsy collection techniques, how to do those, the indications, the instruments needed, and the fixatives that are very, very important towards choosing the proper fixative. So again, I was the lead author with this. I'm very proud of this document, and I highly recommend everybody getting a copy of that. The things we talk about today, we're talking about common biopsy techniques and really how to process these as an assistant, and really how do you submit these things to a laboratory. And this is going to apply to whatever laboratory you use. If you send it to your local hospital, you use a different lab from Bako Diagnostics, that's your personal choice. Everything we talk today will apply to any of the laboratories. There's nothing unique here other than maybe the ENFD, which every laboratory has their own way of processing that. And we talk about biopsy techniques. We're really talking about the punch biopsies, the shave biopsies, curettage biopsies. That's kind of the mainstay of what we do for podiatry. An incisional biopsy is a little bit more aggressive. You take a little bit larger area. Nail unit biopsy is not clipping a toenail to send a specimen for fungus. This is an actual nail unit biopsy to rule out a malignancy or something serious. Ulcer biopsies is really generally done with a punch. Fine needle aspirational biopsy is for small fiber peripheral neuropathy, and basically bone biopsy, skin flaps, etc. That's kind of the common techniques that we use in our practice. If the podiatrist that you work for, if you're unfamiliar with all of these things, then certainly we would encourage them to download that booklet and start learning these too. The instruments here are basically pretty common. If you look from left to right, you're going to look at let's say this is a 2 mm punch biopsy with the little red plunger. I really like the red plunger because it helps get the specimen out of the tube here, especially on a 2 mm punch. The 3 mm punch does not have the red tube because this is the same one we use for an ENFD biopsy, and we do not want the plunger because you need to be very gentle with that tissue handling technique. You can either use a number 10 blade, which is retractable, or you've got the stainless steel ones. The saucerization, which is the bendable blade, is pretty fun to use for shave biopsies. A curettage has a little bit of a loop to it where it's sharp only on one end. That's a scraping technique. And certainly everybody here has probably seen a needle and syringe for fine needle aspirational biopsies. And that's mainstay. I mean, that'll cover 99.9% of all the instruments that a podiatrist uses for biopsies in their office. So let's step back a little bit. What is a biopsy? A biopsy is very specific. It's a small sampling of tissue to send to a laboratory to get a definitive, objective laboratory diagnosis of kind of a strange skin condition. Now, the challenge is, as a physician, we see all sorts of weird things coming into the office. Is it a rash? Is it an infection? Is it a fungus? Don't know. They all kind of look alike on some patients. On an elderly patient, again, it can be very challenging. Okay. Is it eczema? Is it psoriasis? Again, all of these things, we as a physician are guessing as to what they are using a differential diagnosis. So we can maybe try various treatments, creams, lotions, medications, but at the end of the day, without a definitive diagnosis, which is taking a little sample and sending it to a laboratory, we're still guessing as to what this could be. So the beauty of taking a biopsy, it gives the doctors a definitive diagnosis. There's no more guessing, and you can tailor your treatment plan specifically for what that patient has. Now, what doctors do a lot, podiatrists especially, they tend to excise an entire lesion and they send it to the laboratory and they say, I have no idea what this is. It's kind of strange. Let's cut it out and we'll send it to the laboratory. Me personally, I don't really like that technique. I like to make a diagnosis first, plan my treatment. Then if it's an excision or surgery, then I go ahead and plan that option. So a biopsy is taking a little tiny sample, 2 mm, 3 mm, just a little bit of sample. You don't cut the whole thing out. You send it to the laboratory, you make your definitive diagnosis, and then you plan your treatment options, whether you use topical medications or injections or laser or whatever you want to do. All of that is perfectly acceptable to me once you make the proper diagnosis. Again, the biopsy is not a treatment of itself, although some doctors will cut the whole lesion out, which is an excisional biopsy that's a little bit more aggressive. I tend to like to do a stepwise approach. Medical documentations for biopsy. Again, just like EMR, just like office visits, just like surgery, you want to have in your medical records, whether it's an EMR or paper, whatever you so choose. Basically, this is all unnecessary. You want to document the necessity for performing the biopsy. Is there pain, color change, rapidly growing or suspicion of malignancy for that lesion? You want to describe it in terms of location, right foot, left foot, third toe, plantar foot, dorsal foot, back of the leg, the size, the shape, the color, just basic one-line descriptions. You want to do a procedure note for a procedure. If you do a biopsy, a lot of time doctors will can their notes for that. Again, that's fine. But what's really important for assistants, especially, is when you get a report back from the laboratory, and this doesn't apply just to pathology. If you send out a patient for an MRI, you send out a patient for blood work, you send out a patient for a second opinion, you cut a piece of skin or bone to send to the laboratory, you'll get a report. You could even have patients do COVID testing. And if you get that report, the physician needs to indicate in their medical records that they received the report. Did their diagnosis change? I mean, did the doctor did it confirm or change the diagnosis, and what treatment plan is being made as a result of that? A lot of times doctors will get the report, they'll highlight it, they'll sign it, they'll highlight it in yellow, and then they'll put it back in the chart. That is not acceptable. You physically need to incorporate that into your medical records. If you get audited and you haven't done that step, that could cause a little bit of an issue. Now, that could be done on the next visit. So if the patient's coming to the office a day or two later, you can do all of that together. But generally, I like to just document in the notes that the laboratory report was received and get it done pretty much immediately so you don't forget. If you have a phone, you want to take a picture of this or grab a screen grab, the common skin and nail biopsy CPT codes. This is not a lecture on billing. This is basically the most common codes that are used in podiatry for biopsies. So what's really important here is all of these codes changed in 2019. So if you have older CPT codes from 2018, 2017, God forbid from the 1980s, because your doctor never changed their CPT code little form, basically these are the new codes. The CPT 10102 for tangential biopsy, 11104 for a punch, 11106 for an incisional biopsy, and a nail unit or plate is 11755. That's the only one that actually did not change. So all of the above here has changed. So I would make a mental note of that. Now, this is super, super important. This is a brand new slide. I've never showed this for any of the meetings, the FPMA, any of the national meetings, even the doctors. This is a slide I created specifically for this audience, and I will probably use this in a lot of my lectures for 2021. And this slide has the specimen collection medium for pretty much all of the type of biopsies a physician does. And this is really nice and organized. So for example, if your doctor does a skin biopsy, it doesn't matter whether it's a punch biopsy, a tangential, a shave, an incisional, all skin goes in formalin fixative. Simple, easy. That's where skin goes. You don't want to send skin samples dry because it'll dry out and evaporate the water content. If you cut skin from a patient, you put it in formalin, okay, which is like a diluted form of formaldehyde. If you're going to do something like a web space scraping, that's a brand new test that Bako Diagnostic developed in January of 2020 that was launched at the FPMA SAM meeting, and all of a sudden COVID hit 2 months later. So the lab is spending a lot of time on doing DNA testing for COVID. The fact of the matter is this is a brand new test. It's applying DNA PCR technology for web space infections where maybe you don't know whether it's a tinea, which is a fungus, or a bacterial infection. This is using the same PCR technology as COVID testing, applying it to podiatry for web space, and it was done before the COVID infection took out. So the fact is that a lot of doctors haven't started using this yet, mainly because they're unaware of that. We will have lectures just on this web space DNA testing, and it's really, really cool. But web space scrapings are sent dry. If you want to do DNA testing or PCR testing on anything, even if you go for a COVID test and they put the nasal swab up your nose, you're sending those specimens dry or in the little fixative medium. What happens is you don't put that in formalin. If you put that in formalin, you pretty much destroyed the opportunity to do DNA testing. If you're going to do nail testing, meaning fungus toenails, you have really a choice. We prefer those to be sent dry in the dry keratin bags, which I'll show you in a minute. You can do not only staining, which is the PAS or GMS testing, or even DNA testing. You can do it all from a little Ziploc bag. If you have a nail matrix, let's say you have a a paronychia or an ingrowing toenail, or you have something that you think is cancer, the black streaking of nails, or the doctor's going to do a punch biopsy in the matrix. You're not looking for fungus here. You're specifically thinking it's something significant. Those you can actually put in formalin. That's perfectly acceptable because you're not doing DNA testing. The confusion comes a lot with aspirations when you take a fine needle aspirational biopsy. And what happens is you're getting fluid. You're taking fluid from a ganglion cyst or from a gout or something that there's an inflammatory process. The doctor is going to stick a needle in somebody's foot or lower leg, and they're going to suck some fluid out. Most of the time, you're going to put that in an alcohol fixative. And the problem is that alcohol and formalin look almost alike, and I have a photograph to show the differences. The key here is if the doctor thinks it's gout, which is a crystal white substance, that has to go in alcohol. If you put it in formalin, basically it's going to destroy your specimen. However, if you have ganglion cyst, okay, where it's a clear yellowish fluid, you actually could put that in formalin, or you could just put it in an empty sterile cup if you really want. So if you have a fine needle aspirate that is anything other than gout, you can put it in formalin, you can put it in alcohol, you could send it in a sterile cup, you could even send the syringe itself, just don't send the needle. However, with gout, you have to go in alcohol. The ENFD, which is epidermal nerve fiber density, that's a special test where you're going to put it in Zamboni's fixative, rinse, and cryoprotectant. Much more complicated, and that's a 3-step process. If you're unfamiliar with what I'm talking about, that probably means your physician is actually not incorporating that into your practice, and that's perfectly fine. But that is for small fiber peripheral neuropathy. If you have bacteriology where you've got an ulcer or wound, you do a little culture. I love those e-swabs. The beauty of an e-swab is it does aerobe and anaerobes, and basically it's going to do both. So what happens is you don't really want to just take a Q-tip and send it off to the lab in a Ziploc bag, although you could do that if you are maybe across the street from a hospital and you have no other option. You quickly do it and you pretty much have one of your assistants run that to the hospital very, very quickly. But if you're going to send it to a lab like Bako, it generally takes 24 hours to get it to the lab. You're going to want to do an e-swab because that's going to preserve both the aerobes and anaerobes. Finally, if you have bone, whether it's infected or non-infected, you can put it in formalin or a sterile cup, either or. I generally like formalin for most things, but again, sometimes if you're going to do a digital amputation or you cut off, let's say, some bone from osteomyelitis, you can actually put that in just a sterile cup and send it out. If the bone is infected, you also want to do an e-swab of that infection also. So let's look at some of the mediums here that we recommend for sending specimens. This is a dry keratin bag, which is really nothing more than a Ziploc bag. If you actually run out of these, you can literally use a Ziploc bag from Publix or Walgreens, and you basically take a clipping of nail and you put it in the little baggie and you send it off. The few things that you want to know. Number one, you really need maybe a 6mm by 6mm, which is a relatively small piece of nail. You do not need to fill this bag with toenails. You don't. Some people stuff that with every toenail that's cut from the patient. You don't need to do that. You need to choose the most representative sample and send it to the lab. That being said, I do have another slide later on where basically you want to not only send the nail, you want to do the little bit of the subungual debris, which is that flakiness below the toenail, and send that in the bag also. The web space infection, which is a DNA testing for web space infections, is a brand new test. You do a scraping, let's say between the second and third toe, the fourth and fifth toe. You're going to use a little curette. You can use a 10 blade, pretty much anything to scrape that skin. You're kind of flaking it off into these little cards. And if you don't have these derm packs in your office, then certainly send a note to Bako. They'll send you a few of these. But basically, it's a cardboard little piece of paper that you put the sample on the blue side. You fold the two ends together and the two tops, and you kind of have an adhesive that stick together. So this is kind of the top and bottom of the flat cards, and then you put your specimen here, and it's just a little bit of scraping. And what you do is you fold up the two sides, and you tape this, and you put the patient name, and you can literally put this in an envelope and send it off to the laboratory. Sterile cup. This is for bone, digital amputations, or even gouty aspirations. The key here is you want to make sure that these sterile cups have the sticker on here indicating that it's sterile. If this sticker is broken or somebody has unscrewed this, now you've actually contaminated that actual cup, and I wouldn't use that at all. In a situation like that, again, you maybe you could put it in a microwave to sterilize it in a pinch. I generally don't like doing those things, but look, we're all practiced sometimes that the doctor says, hey, I need a sterile cup, and you don't have any. What do you do? Again, your goal here is to try to get the medium that's appropriate to send off to the laboratory. An ENFD punch is much more complex. This is a three-step process. You'll take a sample. You'll first put it in the Zambonis fixative, which is the cap in orange. You'll let it rest for about maybe 8 hours or so, or overnight. The next morning, you'll come in. You'll rinse it with the vial in the middle to take the Zambonis fixative, which is a weak acid. You want to dilute that, and finally put the fixative, which is the blue cap, and then you're going to send it off to the laboratory. So the next question becomes, okay, what do I do? Do I do formalin vials? Do I do alcohol vials, or I do sterile cups? So I took the chart that I gave a few slides ago and I reversed it. So now what I did was I put the fixative on the left and the conditions on the right. If you have a cell phone, this would make a really good time to take a photograph, because I've not seen this chart in any other lecture. I literally created this chart just for this audience today, and I will be incorporating this into my lectures for 2021. So formalin is basically a 10% neutral buffered formaldehyde that is in a little vial. You can use formalin for skin biopsies, punch, tangential, incisional, nail matrix, bone, infected or non-infected. As I said before, if you have an infected bone, also do an e-swab. If you have aspirational, fine needle aspirational, and it's not gout, you could also put that in formalin. So kind of the trick question here is, if someone says, what do I put this specimen in? If you just say formalin, you're going to be right 90% of the time. The time you want to use alcohol, specifically reagent alcohol, 100%, that is for fine needle aspirational biopsies of gout, which are the whitest crystals. Now you can use it for non-gout too. So what Bako does is they pretty much have a aspiration kit that it doesn't matter whether it's gout or whether it is a ganglion, you can put it in alcohol just to make things easier. The sterile cup, again, generally for bone, whether it's infected or non-infected. So looking at the two packages, these are easy to confuse. The one on the left is a collection transport kit with 2 vials. That is the one with the white cap. That is formalin. Okay, that is for your skin biopsies. The aspirational or gout has the green caps on here. That is alcohol. So formalin is white, alcohol is green. You kind of don't want to mix these up, especially for gouty type biopsies. Looking from the side, the white cap is the formaldehyde. This is, again, is for skin, nail, aspirates, even bone can go on there. But the reagent alcohol with the green is specifically for gout or for even ganglion or fluid aspirants. So kind of don't get these confused. There's also space to put the patient's name, age, and identifying information on there. The e-swabs are kind of cool. These are the same things that they'll use for COVID testing. If you've had the pleasure of having one of those put up your nose, like I've done that a few times. But basically, you're going to take this little swab and you're going to swab the foot or the ulcer or wound with the tip, and you're going to put it in the vial and break it at the little marker. The little pink marker is where the Q-tip will break in half. So this is for really infections or bacteriology. The steps here, the first one is it's in a sterile pack. You're going to open it up, and you're going to be always careful to keep the tip of that sterile. Holding it in the left hand, this is the sterile tip here. You're going to give that to the doctor. They're going to now swab the ulcer, and generally the assistant is going to hold this, unscrewing the cap and making sure not to violate the sterile contents in the vial. The doctor or you, the assistant, can now put the specimen with the tip into the container all the way at the bottom and then snap it at the little pink area. So basically you're going to fold in, as long as it goes all the way to the bottom, you just bend it a few times and it snaps off quite easily. You put the cap on, patient label, end of story. So this is the same technique that if you get COVID tested or ulcers or wound cultures, that's exactly what you're going to want to do. The other thing I want to talk about is nail specimen collection. A lot of doctors get this wrong, so we're not here to embarrass the doctors. But a lot of times, the patient on the left is a typical patient with onychomycosis. You do not, I'm going to repeat that, you do not want to send a distal clipping, which is just the clipping of the tip here. That would be wrong. You want to get the clipping of nail all the way back where it's growing closest to the patient body, which we'll call the proximal area. So the middle picture, I started clipping this patient's toenails and I threw all of that away. And at this point, this nice hunk on the side with all this wonderful subungual debris here, that's the specimen that I end up sending to the laboratory, which all the valuable growth is in this little region right here. If you send distal clippings, which is way up here, you're risking getting a negative result. So what do you do when you look for laboratory staining? You've got two choices. Okay, you can do the PAS staining, you can do the GMS staining, and you can do the Fontana-Monson staining. Those are the top three. Me personally, I always go for the PAS plus GMS together because it's going to give me my maximum sensitivity for fungus, meaning if there's fungus there, it will be positive. However, this test just says positive or negative fungus. It doesn't actually identify the genus and species. And I'll get to that in one quick second. The Fontana-Monson is also a staining. It's to be positive or negative for melanin, or these pigmented saprophytes, which is a type of a fungus in toenails that we see quite often. The most exciting one of all, again, DNA testing, COVID testing, PCR assay. The same thing that is being done for COVID is done for toenails. Now, realizing this test for toenails has been around probably 5 or 6 years, but it's using an algorithm where you send a dry specimen of nail to the laboratory, and they're going to screen through a basically screening. They're going to say, is there a dermatophyte, saprophyte, yeast, or a bacteria? If the answer is no, the test is over and it's done. If the test is yes, we see a dermatophyte, then they're going to send in a reflex, which is a series of 4 probes looking for the conditions on the right. The beauty of the DNA testing for fungus or nails is that you are going to identify the most causative agents in onychomycosis, which are these 15 or so on the right. Those are the ones that we see causing 99% of onychomycosis. Now, what do I do in my own office? If a patient comes to me and says, hey, Dr. Shear, I have this terrible toenail and I want to get rid of it. I want it cured. I've suffered it long enough. I will do a combination testing, which is really pretty much all 4 tests. I'll do a PAS test and a GMS test and an FM test to screen whether there's fungus there or not. Or is it microtrauma or psoriasis or something else? Then I'll incorporate the PCR DNA testing to give me the genus and species. So I'm getting maximum amount of laboratory data on one toenail sample. It's the highest sensitivity and high specificity by doing all 4 tests. Now, yes, that will be a little bit more expensive than doing one test at a time. But again, most of my patients are Medicare. These are all covered by Medicare, and basically it's very appropriate. If you get patients on private insurance, you say, I want to do a stepwise approach, you certainly can start by doing a PAS first. And if that's positive or negative, go to the GMS, going to the FM, and finally the DNA. Me personally, I don't like that technique, although it's perfectly acceptable. I like to go in and get me the maximum amount of data from day one. The web space test, I'm not going to spend a lot of time on this because I'm getting close to the end of my lecture and I want to reserve some time for a question and answer. This is a brand new DNA test to identify web space infections. You take a little scraping of that skin, you put it in the origami, a little blue foldable envelope, and you send it off to the laboratory. And basically the lab is looking for 5 different things. Is it a fungus? And what type of fungus is it? Is it a bacteria? What type of bacteria is it? The fungus, we're really looking for the dermatophytes or candida, which is tinea pedis or yeast. If it's a bacteria, is it gram-positive, which is Staph aureus, or the really bad one, which is MRSA, or is it the erythrasma or the corynebacterium? Or finally, is it gram-negative? And basically, once you have that information, you can now tailor your treatment plan for your patient. There's no more guessing with a web space infection. So I can look up these patients here. I have no idea. I think it's a tinea, or I think it's a bacteria. The beauty of this web space testing is that you're able to determine pretty much precisely what these things are. The last things, the requisition forms, I won't spend a lot of time on this, but basically always include the patient information, the date collected, the insurance information, but clinical images. I love when doctors take photographs of patients and they send it off to the lab. If your doctor is taking photographs of patients, please use the digital upload to put that clinical image with your patient report is really valuable. You'll get that'll help the doctors when they're looking underneath the microscope. The next thing here, as far as nails, do you go with the highest sensitivity, the higher the routine? Me personally, I generally always go for the higher sensitivity, which is a combination PAS, GMS, and FM. Those are the staining, but then also I'll do the PCR. So I'm clicking two boxes on this form, the higher sensitivity box and the PCR. I never, ever, ever do the cultures anymore. I did that 20 years ago. Some doctors are still doing that. I recommend you stop doing that. Finally, again, these little the specimens, the rec forms on the Bako, you can actually write it on the form, peel these, stick it on the specimen. I love that. And make sure the physician signs that little yellow box, and that's really needed for compliance reasons. So other than that, I've taken the complete 30 minutes. I think I've gone a little bit too long on this by about 2 minutes, but I will save time for questions and answers. And Karen, if you want to open this up to the audience. I've got a few. You can submit a question via chat. If you go to the chat button, I see there's just a few behind the scenes comments on there. And other than that, Linda, how about you? Click your button and say something.
I just want to say, I think you've been very informative. Everything that you've shown, this is what we do in our office. And I think it's very good to let us all know that.
All righty. Well, thank you for logging in. Mark Sharon, Dr. Sharon, do you have any questions there?
Simply, how do they get credit for this? So,
well, that's going to be up to Karen. I don't know how they do that. I have nothing to do with that. So maybe Karen, you can follow that up afterwards. William Beepin, how are you there? William, do you see me here? You need to click the mute button there. Do you want to, any comments there?
Yeah,
Perfect.
I see. Can you hear me?
I hear you now.
Yep. Enjoyed it very much.
Thank you. Natalie, I see you there. I'm picking on anybody that I can see a live video and just to say hi, because we're going to use the technology. Is kind of cool. So Natalie, I see you down there. I see you doing this. Come on. Just click on your mute button and say hi.
Hi, can you hear me?
I can hear you now. A little echo, but any thoughts, any comments? How you doing over there?
We're fine. We have the whole crew here. I don't have any questions right now.
I feel like in a Miami Dolphin game, you got that echo going on back there. But anyways, thank you for logging in. Janie Wilkinson, I see you logged in there.
I can't hear him.
Okay. There you go, Natalie. Thank you. Thank you. Janie Wilkinson, I see you there. I see all those beautiful charts behind you there. Do you want to say hi to the audience and any questions on or comments on our presentation? You got to hit the mute button. I don't hear you. You're on mute. Janie Wilkinson, you've got, if you go to the bottom of your screen, there's the mute. You can unmute on your screen. It's part of your Zoom button. You have to go to the bottom and click there.
it's on the top right of mine.
Oh, you're on the top right? Okay, you're right. Maybe way at the top. I guess it depends what screen you're looking at. But Janie, I can see you. I can see you're talking, but we don't hear you. If anybody else is logged in that I cannot actually see, I see there's quite a few people that I see their names that logged in, but I don't see their pictures. If you have the ability to click on the mute or unmute button, we can hear you and ask a question. Other than that, we're just going to use a few minutes just to kind of chit chat a little bit and talk about this. Well, Karen, do you want to, any other things you want to follow up with? You want to conclude this? If any, oh, by the way, if anybody has any questions, okay, and this is something I'll offer here. If anybody has any questions that were not answered in this presentation, or you say, oh, I was a little embarrassed, I didn't want to ask this live, send an email to Karen Lambert. She'll send me the email and I'll actually try to answer that to the best of my ability. Now, it might take a day or two, but I will try to do that. So, other than that, Karen, if you want to maybe say some concluding marks, I do want to thank everybody for taking the time and logging in here. If you missed the beginning, I encourage everybody to go to the FPMA SAM meeting in January. That's at the Disney Coronado Springs, and make sure if you're an office manager to get your podiatrist to pay for you to go to that meeting. It is a fun meeting, and you can use me. Throw me underneath the bus. Dr. Shear said we should go to this meeting, and the SAM meeting is always wonderful. Karen? Oh, wait. Natalie is saying something. Natalie, go ahead, unmute.
Jillian wants to say something.
Good afternoon, doctor. There's about 8 of us MAs in here watching your tutorial webinar, and we were wondering maybe what the difference between using the alcohol versus
The formalin.
Yes.
Generally speaking, if you cut out skin or nail, you're going to put it in formalin or even bone. The challenge is if you're going to do a fine needle aspiration, or you take a needle and syringe and try to suck fluid out of a lesion, I would always put that in alcohol, because you can't go wrong with alcohol. If you put it in formalin, you're still okay unless it's gout. If you put gout in formalin, it destroys it. And you don't want it.
Wow. So we should, okay. Thank you.
Okay, and that's the green cap.
Yes.
Any fluid, anything that's liquidy, put it in alcohol.
Okay, thank you so much.
All righty, Karen, do you want to wrap it up or any other last minute stuff?
Dr. Shearer, I want to echo your sentiments and thank you personally for your presentation here today. I mean, this is exciting stuff. Thanks to the team with Natalie there and asking these questions. Thank you, Bako DX, for support of FPMA. We are grateful for the extended partnership, and thank everyone for taking time out today. We appreciate you being on the webinar.